as Tony said, my name is Sue Loughlin. I'm a member of the THNS organising group. And my job this morning is to introduce Kat and to manage a little short Q&A after her presentation. Kat and I first met quite a few years ago when we were involved in a sister organisation called Politics for Health Groups. So we have a bit of a track record together of health activism. And Kat has also been involved in the Civic House movement in Scotland, particularly in the development of the manifesto that Tony has just mentioned. But she has a day job as well, which is unfortunately often the case. She's Professor of Public Health Policy at the University of Strathclyde, where she co-directs the Centre for Health Policy with her colleague Ellen Stewart. Her work focuses on analysing how policies impact on public health and health inequalities and who influences those policies and how. Hopefully it's all of us. She is currently focused on methods for improving public engagement with the debates about health inequalities in Scotland and the wider UK, and has been running some citizens' juries on health inequalities. She published 75 articles and 5 books on these topics, so no slouch, including The Unequal Pandemic, COVID-19 and Health Inequalities and Health Inequalities Critical Perspective. In fact, she helped us with the COVID inquiry that Tony has just mentioned. She and we are aware that there's a lot of expertise and knowledge in this room, but we particularly asked Kat just to set the scene about what the current situation is in Scotland. So over to you, Kat.
Great, thanks very much, Sue, and hi everyone, lovely to see you all. So my opening slide, I've got this picture of Sugar Bane, a novel set in Scotland. And I'm going to return to that later on in the talk, but it kind of gives you a signal of one of my key messages, which is the importance of stories and telling stories to persuade and influence. I'm going to start with a quick kind of recap of where we're at with health inequalities in Scotland. So late last year, November 22, the Health Foundation had commissioned a series of work about health inequalities. This report, published by colleagues at the University of Glasgow, Anna Pearson team, they were looking at all of the data trends in relation to health inequalities and seeing where we're at. And so it's kind of one of the most up-to-date summaries. And so this, I'm summarising here what they pulled out as the really key findings. So mortality rates and inequalities were falling. So over the periods up till about 2016, they were kind of, it depends which indicator you look at, they were falling, and then they're starting to widen again. And there's some really concerning health outcomes over the last 8 years or so. Health consistently worsens as deprivation increases, which we've known for a long time. But there's various indicators in which the most disadvantaged groups in Scotland seem to be pulling away, and things seem to be getting substantially worse in the last few years. So really concerning. Young and middle-aged men are faring particularly badly for some outcomes. Children's start in life, as we know, is not equal. That continues to be the case and is worse, getting worse in some indicators. And inequalities in health-related behaviours, like they play a role, as we know, but it's a very complex role. So these, I think are things that we may know, but I just wanted to put some of these kind of up-to-date charts. So there you see the kind of most disadvantaged, so this is avoidable mortality, the most disadvantaged group at the top kind of pulling away. So this is for men. So so you see the gap widening there. For drugs deaths, you see this really concerning peak in the last few years. Like, I mean, it's really quite breathtaking. For low birth weight, we see the kind of gap getting a bit smaller there in the kind of around 2010 and then widening again. And then for alcohol deaths, this is just a kind of signal, the complexity of what are often called lifestyle behaviours, because we know that alcohol-related harms are higher in more disadvantaged groups in Scotland, and quite substantially so. And we know that alcohol plays a role in violent deaths and suicides and so on. But we also see, when we look at consumption patterns, right, the opposite is true in terms of where consumption patterns are highest. They're higher in the more advantaged groups on average, like they're lower in the more disadvantaged groups. So it's not a simple story of health behaviours are worse in more disadvantaged groups and therefore harms are worse. It's quite complex. So that's the kind of picture of where we're at. So it's not a pretty picture for Scotland. And as many of you probably know, Scotland also suffers from this excess mortality. So in relation to we'd expect health inequalities and we'd expect the levels of deprivation that Scotland has to be impacting on health negatively. But over and above that, if you compare the Greater Glasgow area to the Liverpool and Manchester, we have an excess mortality. It's sometimes been called the Glasgow effect or the Scottish effect. So it's been a consistent policy focus. So since political devolution, so if we look at from 1999 onwards, there have been multiple big kind of policy publications about tackling health inequalities. It hasn't ever gone off the policy agenda. And there have been consistent kind of governments in power that have committed to reducing health inequalities. So a lack of policy interest or even activity in terms of like getting ministerial task force together or publishing strategies, that has not been the problem. So what has been the problem? I'm going to go through 4 things that I think are problematic, and then I'm going to finish up by saying why I think organisations like People's Health Movement are so important and in terms of the next steps. So I'm going to talk a little bit about policy paradigms and how that leads to a situation in which it's really hard to affect change, to achieve change in policy. I'll talk a little bit about politics and power and who influences the policies that impact on health inequalities. I'm going to say a little bit about the role of publics in all this, and not just publics as in what do publics actually think and contribute, but how they're perceived in policy terms and in research by researchers. And then I'm also going to talk a little bit about what I call the public health lens, which is a particular propensity to be persuaded by certain kinds of evidence and data, which I think, from what I've seen in policy spaces and in the citizens' juries, is probably quite unique to public health and not always in our favour. So in terms of policy paradigms, so this is the idea that when policy settles on a particular trajectory, you start going down a particular track, and it's quite hard to shift policy away from that track. And so there's this idea of path dependency, which you might have heard of. So the QWERTY keyboard that we all have was designed in order to slow people down from typing, because the keys were otherwise getting stuck. But now we've got stuck with this keyboard, even though we don't need to slow things down anymore. And I see that a lot in policy. So when I speak to civil servants about why they're doing what they're doing, for example, this civil servant here I interviewed, like it was years ago, but I've heard this story a lot. So I say, what happens when a new problem comes up? And he said, well, the first thing that you do is you go back in the files and you see what you said last, and then you speak to one another, and then you try and figure out what the ministers really want, what's feasible, what's particularly this, that, and the other. So you can see this process in the civil service of once policy, like a particular approach, it's set in and institutionalised. It's hard to move away from them. And because of this, I think certain evidence gets into policy, and as I'm going to come on to say, I think a lot of medical evidence travels into policy quite well, and more social determinants of health evidence struggles a little bit. So there's 3 policy paradigms that I think are problematic in Scotland for health inequalities. So one is the idea that traditional economic growth is the fundamental policy priority. And so about 15 years ago, when I was interviewing policy people, people in the Scottish Government were quite clear that traditional national economic growth was the main priority. So you could only really get traction on an idea if you could translate it into that term, if you could show what I was going to contribute in economic terms. Right, that shifted a bit because now we have this idea of wellbeing economy, and some people are saying, well, maybe national economic growth isn't the thing that we ought to be most focused on. But actually, there's all kinds of agreements that the Scottish Government has signed up to, which make it really hard for them to move away from that priority. A second one is a medical model of health. So you see that in the way, who's given responsibility for reducing health inequalities? There's lots of chat about it being a cross-government approach, but actually it's usually mainly people in the Directorate of Health that have responsibility, and they are organised into teams that reflect a quite medical model of health. So that's how you get ideas that fit that medical model travelling well, ideas that have a more social approach struggle to get into policy. And then the final thing, I'm going to give an illustration of this, is governance biometrics. So this is the project I'm working on at the moment. It's called the Civic Consortium, and it's supposed to be in this wellbeing economy space, right? And so it's got Scottish Government as a partner, and the whole idea of this project was that we co-produce the research with Scottish Government, and it's about making this upstream shift towards using economic policy levers to reduce health inequalities. And there's a lot of goodwill and commitment there. But when we try to study what this idea actually is, wellbeing economy, everyone we spoke to had a different version of wellbeing economy. And so my claim here is that it's a chameleon idea, right? It's an idea that it works partly because you present it differently to different audiences. And that makes it appealing. It helps get people around the table. It helps build a coalition, but it makes it really hard to operationalise. Now, this Stanford project was supposed to be using complex systems modelling to operationalise, to help policymakers think, well, which policy levers would we focus on if we want to achieve wellbeing economy and reduce health inequalities? And so we developed with policy stakeholders this complex systems map of wellbeing economy. Now, I can't even show it all because it was so complicated, right? There's all the dots in the middle there. And then we kind of took it to the modelling teams, and they were like, we can't possibly do anything to do with that. So we need longitudinal data. So we're going to look at what's in Understanding Society, which is long-standing longitudinal data survey in the UK. And we're going to focus our modelling on that bit. And so you see this transition from a fuzzy, complex idea to actually something that is addressed by questions which were designed decades ago, right? And they've been running for a long time. And so you see the way in which it's quite hard to escape decisions that were made in the past, and this kind of simplification through metrics. And I see that again and again in policy. So then the second thing is politics and power. So I'm also involved in the Spectrum Consortium, and that's looking at how large corporations influence policy. Now, it's mainly focusing on corporations like alcohol corporations, tobacco, ultra-processed food and so on. And there's really good work in this part of public health, especially work that's tracking through tobacco industry documents. There's lots of internal documents, so you can see all their strategizing and efforts to influence policy. But it's kind of stayed in the corporate determinants of health bit, right? And actually in health inequalities, we also need to be thinking about who is influencing policies and how. And some of these same companies are influential in this space. So when I was a postdoc researcher, I had a job for a while working on tobacco industry documents, looking at how they tried to influence policy. And this document from British American Tobacco was basically setting out why they were supporting a right-wing think tank. So it's the Institute of Economic Affairs. And they say, you know, there's lots of evidence of them supporting think tanks to achieve specific goals, where they specifically are pushing back on a particular piece of tobacco control, public health legislation. But they're also talking about here how they're supporting the Institute of Economic Affairs because it's ideologically in sync with what they as a large corporation want to achieve. And that's kind of that area, I think, in health inequalities research is underexplored. We don't really understand how all these that kind of large scale actors, who it is that's trying to influence policies in ways that actually exacerbate health inequalities. And if we look at what the Institute of Economic Affairs kind of puts out in the public health space, I mean, it rails, Christopher Snowdon often works for them, it rails against a lot of tobacco control, public health legislation, but it's also kind of railed against the spirit level work by Richard Wilkinson and Kate Pickett and so on. So there is a clear intersection here. And then the third thing I wanted to talk about was publics, and it's not really actually what publics think about health inequalities that I feel is a concern, but more what the perception of what publics think about health inequalities is in policy and research. So when I was doing my, I've had various projects where I've interviewed people in research and policy about health inequalities. And over the course of about a 10-year period, from about 2006 to 2016, I interviewed 112 people. Of them, 108 of them said that they didn't think the public would support more egalitarian policy responses to health inequalities. But it was really unclear where this view was coming from. And there was this quite a strong view that people don't really understand health inequalities, they don't understand social determinants of health. If you ask them about health inequalities, they'll tell you about postcode lottery of healthcare and life and differences in alcohol and smoking. That's what people will say. So it's really out of line with policies. And when I push people on where does that view come from, actually they were a bit unsure about where it comes from. So the public are often positioned in this debate as the problem. Right? So I then tried to look at this in a bit more detail. So I reviewed all of the accounts I could see, and I've recently completed a new review with Ellen Stewart, just looking at accounts in Scotland. So this is qualitative research asking people what's impacting on their health. And it's really clear that people have a very good understanding of the interplay of the social terms of health and what things are impacting on their health. It's sophisticated and it's very much in line with academic research. So this perception that people don't understand, especially people at the brunt end of health inequalities, is, I think, wrong. And in fact, lay accounts in some ways, I would say, are better and more sophisticated than some of the research in this area, because it's much better at giving a sense of intersectional inequalities and the way different inequalities interact and shape people's health experiences. And the fourth thing I want to say that I think is a bit of a problem sometimes is this, what I call a public health lens, and it really has taken off in the context of the COVID-19 pandemic, right? So public health researchers are often trained in epidemiology or linked epidemiology, and they love a good bar chart and quantitative data, right? This is the kind of currency of public health. And so you can see, like, there's lots of data dashboards that you can go to now, and there's a movement to try and encourage public engagement by creating more publicly open data dashboards, right? And I am not convinced that this is the way to get public engagement about health inequalities. I'm not even convinced that it's necessarily the way to achieve policy influence in these spaces. So this is an extract that's taken from some research that a PhD student I was supervising did, and she was looking at their Scottish alcohol strategy and how that had been implemented. And one of the things she did was spend time in local alcohol licensing boards and look at how different evidence was presented in those spaces. And in Scotland, local alcohol licensing boards have a requirement to consider public health, right? And that was seen as really innovative. So that's part of what she was studying. And what this person's reflecting is basically that the health people just come along and they have bar charts and quantitative data, and they don't tell a good story. So he said at every meeting, the police, the building control, the licensing guys and the health are expected to be there. Unfortunately, the health guy just reads everything he's written, and that's it. They're thinking, I've read this, I don't need to see it again. And that frustrates me. A trivial point, but it annoys me, because that's your opportunity yet to put up an official document. Now, tell your story. Tell your story about how it's going to damage people in your community. This is his opportunity, and kind of indicate that, like, he doesn't take that opportunity. And that brings me back to this point that I kind of started with, which is the centrality of stories. And I love this quote from Ben Phillips recently, where he's saying, there's a tendency among some progressives to see themselves as the people of reason over emotion, the people of numbers and facts over myths. We need to get comfortable with conversations which not only make people think, but which make people cry and make them laugh, which make people angry, hopeful, excited and determined. We'll need not only to be teachers for a smarter world, but preachers for a better, kinder, happier one. The fight against inequality is not only rational, it is also beautiful. And I really think, when I think about some of the things that and the people that have been most influential in policy spaces, they cannot all tell a good story. Right? They use the data, but they use it to tell a good story. So I'm not talking about separation, but I'm talking about telling good stories, important, persuasive, moving stories based on the data and the evidence. I think Darren McGarvey is part of the reason he's really popular is he's really good at telling that story. It's really moving stories which really capture the social determinants of health and the way in which politics shapes people's lives and the long shadow that political decisions can cast over whole communities. Shugi Bain too, so this is not a factual account, but it is grounded in real experience, is also really good at like getting people to think about get beyond the data and think about the actual consequences of policies and how that plays out. And I really like this quote where this is Agnes, if you haven't read the novel, Agnes is the mother of Shugi Bain, the main character in it. And this bit here, I think particularly moved me where she was talking about the mothers in this community. It's a kind of pit community where the pit is closed. So separately, they'd lain awake in the quiet of the night, wondering how to make a pit and stretch around. It was a mother's math. And it's that, like, telling those stories sometimes can be, I really feel, much more powerful than a bar chart. And if we look all around, we have really good examples of the stories that we actually try to tell in people's health movement and health inequalities research. So things like the ghost town, the specials song, that is a really good account of what happens when certain economics decisions are made to particular towns and so on. So these stories are all around. So ideas for moving forward. So I think we need to appreciate how much we already know. And so there can be a tendency, it's probably not in this room, right, but there can be a tendency in public health to be like, we just need to get better evidence about what actually works. And I'm really not convinced that I think we know enough, right? We know enough to achieve some major gains. I think we need to identify, acknowledge and kind of challenge where necessary these policy paradigms that kind of get in the way. We also need, as people in research, I think, should be shifting their lens upwards, right? We need to be looking at who is influencing policies in ways that exacerbate inequalities and make them worse, and why, and we need to be calling that out. We need to get better at telling persuasive stories to affect change. And like I say, it's not about ignoring the evidence, but it's about using the evidence and the data to help us tell a more persuasive change. We need to, I think, be doing more democratic engagement, and I've specifically used the word engagement there because I think there's a lot of learning and listening to be done on the side of the kind of experts like me. It's definitely not a one-way story, and I'm a bit frustrated at the moment because I see campaigns by some organisations in the health sector, and Health Foundation is one of them, where they've taken survey-based answers on what people think causes health inequalities, and they've assumed that people don't have a good understanding of social determinants of health. And they now have like an advertising campaign in more disadvantaged communities, trying to tell people about health inequalities and social determinants of health. And I feel that those kind of, it's a wasted opportunity, and it's actually potentially really stigmatizing, right? Instead, we should be having conversations about what are the solutions and how do we work together. So yeah, and the citizens juries that I've run that Sue mentioned at the start, I found those, like that kind of space, really positive. And then we need to be strategic in building alliances and kind of thinking about who we work with and how we come together and how we can work together to achieve politically viable change. And I sometimes get frustrated in the public health spaces because, as I say, I feel this is a tendency to say, but we just need to have clearer evidence on what's the most effective thing that policymakers can do. And I feel no, like we should start with what are politically viable policy changes that we know would have a positive impact across a range of different outcomes. Health is one of them, but it's not the only one. So if I was to sum up why I feel like this kind of meeting today and the people's health movement generally is so important, the three things that I think we need to affect change are more public engagement, including conversations, more advocacy coalitions, which the people's health movement is, and more effective storytelling that persuade people to affect change. Thanks very much.
What a rich and informative presentation that was. Thank you very much. But I think you have summarised very well why we're actually here today, which is to try and bring people into the room who perhaps don't normally come together and try and do some of that coalition building and discussing about how we create synergy between different forms of the ways that the social determinants affect health. You know, we can't ignore the environment, for example. We can't ignore what's happening to women, for example. We can't ignore what's happening in the NHS. Particularly because a lot of policymakers, as you mentioned earlier, actually think that managing and dealing with health lies solely with the NHS. That's still the hurdle that we have to overcome. We have a little bit of time for questions and answers, but really the main thrust of the rest of the morning is to try and pick up from what Kat's saying and take it into the workshops that we've organised. But you know, if you do have any really pressing points or any key questions that you want to ask Kat, we can spend a short time on that. And
yeah, thanks very much. Now it's not really a question. I just wanted to say how profoundly relieved I am to hear the way that you have come to conclusions and certainly restored it's 10 years, we haven't done so much in therapy, research. I represent different bodies, and the convener of the Alba Party Health and Wellbeing Group formulated party policy on that issue at the moment, also common real. And I have, I do my own integrated medicine. But the thing that gives me great pleasure this morning is if we hear a professor of public health policy really talking about we really do have all the metrics we need. We don't need any, and we emphasise it in the party set up that what we need to do is get down and start doing something. But what we do need is a very firm backup from the likes of yourself, so that when our political opponents turn upon us and say that we're oversimplifying things, or we're not into the space that we can. So I'd like to have possibly some kind of formal relationship, whereby we can get ahead, make our policy objectives and time limited. At the same time, not worrying too much about us sending out a stream of information, what you've already done. So, I'm really grateful to you. I enjoyed your presentation. Thanks.
Anybody else like to make a quick comment or a question of Kat? Yes.
Sorry, I was a bit big for it was. I live in Glasgow, and we had a public meeting recently. And I looked at the multiple indicators of social degradation, and we're in still. Now, a lot of money is coming to government. And I heard what you just said, it's not all about the National Health Service. In fact, it's not all about health, as the indicators around housing, around terrible problems in protection and drug addiction. Now, how come we've got all this investment and it hasn't raised us out of the multiple indicators of social degradation? The agencies are not wanting to be critical of the agencies. There's a lot of good workers in the housing associations. So I would be maxim that there's do nothing for us without us. So this concept of public engagement with the people who live in areas such as government is problematic. I'm very involved with it, and we do lovely things to call the recovery through nature. We do lovely things to the little farm. And the young man who heads that up, Matthew, told me yesterday that there's been a statistic that there's only something like 27% of the local population ever gets involved in the thing that we call consultation. So we've got beautiful big flats, and see over the river now, and stuff. So around housing, around truckers, we have not enough recovery services. So it's all of that your wonderful presentation indicates, and yet here we are, 10 years down the road with a lot of money coming in, and we're still in the worst five in Scotland.
Yeah, so we, like I said at the start, it's not for a lack of activity, right, that we still have really bad health inequalities in Scotland. I do feel that there is a tendency in Scotland to and includes researchers, I would say, to focus on influencing national level policies and national level policy debate, and not enough attention on how that's like tracking down being experienced by communities, or the opposite, starting with communities and what their ideas and views are, and then pushing back up again. So that, like, if I think about a lot of the work that I see in public health policy, it's all about influencing national level policy debates. It's not about really understanding what's happening at the local level. So that's one thing. I also think, like, I'm really interested in your views on public engagement. So I feel like part of the answer lies in having greater democratic engagement, greater local level participation in what some of those bigger policy decisions should be, and why they're playing out the way they are, and getting people's voices from places like government heard in a much kind of louder way in some of the rooms where like the higher level decisions are getting made. So it's local, but it's also national. So that's that would be my view. But I definitely, as a researcher, I'm committed now to focusing less on just this national level and tracking policies down, because I just in Scotland see a lot of nice rhetoric in policies, a lot of references to evidence, and the policies all look quite nice, but they're just not they're not having the effects that we all hoped that they would have. That's just not what's happened. And I think if you take that position of starting with the local community and that actual experience, you can pretty quickly understand why that's the case.
It's also maybe because those resources aren't as big as you're actually suggesting to solve the problems that government has, and it's focused on sort of marginal activity rather than changing the fundamental reasons, like housing that we mentioned. And again, that's why a campaigning organisation like the People's Health Movement, which tries to recognise that health is a function of all of the things that matter to us in life, have to be taken into account, and we have to push on all of that. Unfortunately, we haven't really got the time to take any more questions, but I think Catherine has stayed in the morning, is that right?
Yeah, and I'm just like on that point about the money, like if we look at some of the indicators I had at the start, like where they start getting worse, right? They start getting worse around 2010, and they basically start getting worse as austerity politics are implemented at the UK level. So there is a connection between the public money going in health experiences.